Well, muchas gracias to you, and thank you very much for the invitation. I'm enjoying very much seeing many of my friends here, as well as seeing the excellent progress and the excellent meeting that Mexico puts on in nephrology. It's really an outstanding achievement, what you've done and what you're doing, and we're all watching. Right now I'll be talking to you about molecular diagnostics and how they can change things. And I'm speaking to you from the point of view of a nephrologist who also thinks that they can change things in primary renal disease. So if your primary interests are not renal transplantation, think about how this could change the practice of nephrology by helping us establish diagnoses that we currently miss. So this afternoon we'll be talking about acute kidney injury and chronic kidney disease and the lessons we're learning from transplants as a model. But today we'll learn about rejection. We'll learn why we need a molecular system and how a molecular system works. Then we'll look at what the molecular system can do in terms of detecting different forms of rejection. These are some of the people who've been working on the project. I'd particularly like to note that Dean is from Egypt, Andre is from Brazil, John Bromberg and Arthur Mate is from the United States, Jessica is Canadian, Declan is from Ireland and England, Ganila is from Hanover, Conrad is Canadian, Lewis is from South America but is Canadian, etc. So we've got quite an international bunch and a set of international collaborations, and I really think this is an example of of the way people can work together. We'd like to have a Mexican component. Now, so we'll talk about what is rejection first. What do we know about rejection? I've spent my life studying this disease, and I think I'm starting to understand it. Through the 1980s, we recognized in looking at patients that there was a form of rejection that wasn't the same as the conventional form. And by 1990, we published a paper that said that this form of rejection, antibody-mediated rejection, was a microcirculation process, an intracapillary process that was distinct from the tubulo-interstitial process of T-cell-mediated rejection. So we said that the typical lesions of T-cell-mediated rejection, such as tubulitis and interstitial infiltration, were not present. Instead, there was endothelial injury in the microvasculature, and that actually turns out to be the basis of the disease definition. This is T-cell-mediated rejection. We think that there's a cognate antigen-specific T-cell recognition process occurring in the interstitium. And then this leads to deterioration of the epithelium with the accumulation of cells enter the epithelium, probably because the epithelium has dedifferentiated and has lost its ability to exclude inflammatory cells. So it's an intraepithelial process, an interstitial process. So what we think happens is cells enter, and the cells enter probably because one T cell has started the process, one cognate T cell, and then it attracts the others. So monocytes enter and become macrophages and dendritic cells, but cognate T cells enter, and the result is a synapse. And as a result, an inflammatory system is put in place, a highly stereotyped inflammatory system in the interstitium, and in consequence, the epithelium deteriorates. And what happens is the interstitial process triggers the acute kidney response of the epithelium. It's wound repair in the epithelium. There's only one response of the epithelium, and it's the AKI response. So that's an active injury repair response of the epithelium. The central aspect of this is probably the synapse between an antigen-presenting cell and an antigen-specific T cell. Signal 1 and signal 2, and that forms the core of the signal we're trying to detect in T-cell-mediated rejection. And I'll show you that later. In addition, there are many non-cognate T cells are probably attracted to the site, and that's part of the strategy, and they may actually play a role in the epithelial deterioration as well. Now, in contrast, antibody-mediated rejection is an intracapillary disease. These cells are an indication that the capillaries are abnormal, but in fact, the capillary abnormality can't be seen with the microscope. The microcirculation changes. Cells are now marginating on the abnormal epithelium, in addition being attracted to the Fc components on the epithelium. C4d is a useful epiphenomenon, but it has false negatives and some false positives as well. This is, of course, C4d staining that you're all very familiar with. The problem is that as we now come to realize, somewhere between 75% and 50% of all antibody-mediated rejection is C4d negative. Now, C4d may be a sign of the more intense reactions, but certainly the sensitivity is poor. So here's what we think happens in antibody-mediated rejection. Two MHC molecules must be adjacent, and so there must be a fairly high density of MHC molecules to facilitate the interaction of IgG and the triggering of the ability of IgG to facilitate complement recognition. Complement recognition results in a lot of short-term mediators, but one mediator, one end product, C4d, has a thioester bond, and it accidentally binds covalently to some of the components of the microcirculation and serves as a convenient marker when all the rest is being washed away. It's not a mediator itself, but it is a useful, sort of useful marker. Now, many cells are attracted, and the one we're very interested in is the NK cell, which has a high affinity Fc receptor, which then triggers the NK cell to produce interferon gamma, which of course will increase the MHC expression. Interferon gamma is a signal, and it induces things like CXCL11, the chemokine, in the microcirculation as well. So this is a conversation going on between mediators and cells and the microcirculation. The NK cell is cytotoxic. It has potential cytotoxicity. Whether the change in the microcirculation is cytotoxic or is some other kind of more complex adaptation, we're not sure. In addition, the NK cell has many other ways of talking to the microcirculation surface, like SLAM proteins, and it can interact even with MHC molecules in different ways. So very complicated conversation. The result is an endothelial distress signal. The endothelium undergoes a reaction. Interestingly, as we look at other diseases, this is the only human disease that probably has this process. We have wondered whether other thrombotic microangiopathies might share this mechanism. We're not sure yet. The very few that we have where we've got microarrays on have not had it, but it may be a question that it's time-dependent or it's phasic. Now, over time, double contours will emerge, and the double contours are time-dependent, and we think that they usually take about a year, and we're seeing this in the studies we're doing with Christophe Legendre and Alex Lupi in Paris, and we're seeing that in people who have antibody-mediated rejection. The signal is there for a long time, but the double contours only appear after about a year, so that's a time-dependent lesion. Now, in our Genome Canada study, we were able to get a large grant to do prospective indication biopsy studies. Consented prospective studies are the way this area will be sorted out. It will not be done by retrospective, let's get a bunch of stuff from the freezer. This has to be consented prospective. And I'll tell you more about that, but at any rate, what we found is, as we observed the patients with their various diagnoses, and we published this in 2009, the early case mix in an indication biopsy study is self-limited or treatable diseases. Vasomotor calcineurin inhibitor toxicity, and acute kidney injury, T-cell mediated rejection. The late case mix is really quite different. It's antibody-mediated rejection. We found that about more than half of these are C4d negative, and some of them are associated with non-adherence. There is recurrent glomerulonephritis, there's a little bit of polyomavirus, and so it's a case mix, though a very serious and often untreatable disease is much more difficult, and the result is that time is a huge determinant of what happens after an indication biopsy. Late biopsies are very bad for the patient's outcome because of case mix. Now, T-cell mediated rejection by itself does not influence the survival after an indication biopsy. And a lot of myths have been built up about this because of misinterpretation of the biopsy studies, and we have taught generations of young people that rejection causes future graft loss. It does not. T-cell mediated rejection does not change your prognosis after treatment. And that's diagnosed by histology. Antibody-mediated rejection has a huge effect on your prognosis, and that's because we don't manage it very well. We don't know how to treat it. There are no good prospective treatment studies of antibody-mediated rejection, and there's no commitment in industry yet to do any phase 2, phase 3 studies which can give us the evidence basis that we need for practice. So the teaching point here is that the belief that rejection increases future graft loss is not correct. T-cell mediated rejection does not increase failure because we can treat it. Antibody-mediated rejection increases failure because we have such poor treatments for it, but it's not inherently fatal about antibody-mediated rejection. It's just a management issue. We have to learn how to manage it. Now, I just wanted to say for you young people, this takes a long time. Progress is very slow. And you could be discouraged by this slide or not. So we described this disease in 1990. So now we can recognize it. Now everyone says it doesn't exist, antibody is nothing, don't worry about it, there's no such thing, etc. So then C4D came along and it made it possible to see some of these cases. The problem was that the pathologists then got together and did one of their consensus chats, and they decided, well, then we can only diagnose if C4D is positive. So this is wrong, but it now has taken another 11 years, and they still haven't come up with a way of diagnosing C4D negative. There's no consensus about the diagnosis of C4D negative. So progress is slow. Don't be discouraged. Now, one of the things, and you saw this slide last night, and I'm seeing this slide in everyone's presentations now. This is Joanna's study, and Joanna's back in Barcelona now, but when Joanna was with us, she studied our case mix, and she did attribution. She tried to account for every failure we'd seen after the indication biopsies, and what she found was, going back to medical records, that about 65% of the failures we could attribute to antibody-mediated rejection or pretty strong evidence for antibody-mediated rejection. There's a set of cases also that have mixed rejection. They're mostly non-adherent, interestingly enough. A set of cases with recurrent glomerulonephritis, of course, you'd expect that. Polyomavirus, and in addition, we found that some cases fail during complex medical illnesses. The patient goes into the intensive care unit with a complex medical illness, and the kidney fails during that period, and maybe the patient survives. So there are other complex causes, but the big problem was that of the cases that failed with an antibody component, about 48%, the physician had recorded independently of the study concerns about adherence. And that's how we've come up with this, and we think that adherence is a major issue in all of medicine and in transplantation in particular. Anyone who manages hypertension or diabetes also knows about adherence problems. So we're part of a much more general problem in medicine. We're developing a molecular score because we think that there's a molecular phenotype of the non-adherent patient, and the molecular phenotype is they have antibody-mediated rejection and they have a T-cell component because of their failure to use the prescription. So that may be how we can actually molecularly diagnose non-adherence. Now, what do I mean by the need for new diagnostics? So this is an unmet need in all of medicine. So pathologists admit that histology is not good enough in their own literature. In 2003, Peter Furness, after a number of international studies among pathologists using the Banff lesions, said that pathologists using the same lesions and rules, not only was the agreement poor, but it was resistant to training. It couldn't be improved. International variation in histologic grading is large, under-recognized, difficult to improve, and almost certainly of major clinical relevance. Urgent steps are required, but obviously histology is not the answer. So when we look at the kappa values, and the kappa values are the chances that two of you would agree on something. And you're assessing something. Now, if it's chance alone, the kappa value will be 0. If you're basically just no agreement except by chance, if you're in perfect agreement, the value is 1. Most BAMF lesions that are important have a kappa value of about 0.2, which isn't much better than a coin toss. Now we're not making this stuff up. Now, why do we get away with it? Prior probabilities. The patient has a phenotype, the clinician thinks it's something, the pathologist sees lesions, and the prior probabilities help us to not make more mistakes. So, for example, tubulitis, the kappa value is less than 0.2. The number of glomeruli present, the kappa value is 0.5. The chronic allograft nephropathy, transplant glomerulopathy, kappa value is 0.11. The neutrophils and peritubular capillaries, the kappa value is 0.13. We're in coin toss country. So why is histology not a good gold standard, not just in transplantation, but in nephrology generally and in anything? It's the best we have been able to do for 150 years, but there's a lack. Generally, the use of the lesions is not supported by proper prospective studies. All the lesions are nonspecific. All the lesions are nonspecific and occur in other diseases. They require subjective interpretation, like tubulitis can only be scored if the tubule is not too atrophic. What? Who's going to decide whether it's too atrophic? So if it's a little bit atrophic, it's okay, but if it's more than a little bit atrophic, but that's a huge requirement for subjectivity. Is it even correct? There are some frankly incorrect rules that I'll show you, like the C4D rule and the isolated V rule. There's inherent ambiguity, like borderline. Half the cases that could be called T-cell mediated rejection, more than half, are actually called borderline. I'm not sure. It could be this, it could be that. I'm not sure. Really, medically, that's something that we've always wanted to work on since the first days of BAMF. And finally, there's changing times. The rules that were made up 20 years ago now face different prior probabilities because much more injury, much more aging effects, much more scarring, much more damaged kidneys that we're putting in, and less rejection. So the prior probabilities have changed. So our approach has been a molecular microscope, and in this we're, like other areas of medicine, we're trying to do this with inflammatory bowel disease as well, but cancer is the area that led the way. And after studies since the 1990s, cancer is now starting to have some successes with this. And the idea is that centralized high-throughput measurement systems on biopsies can add value to the existing diagnostic systems. So these are beginning to impact breast cancer and colon cancer, and the two examples I'll discuss are Oncotype DX and MammaPrint. Breast cancer, of course, has a background in molecular phenotyping because of estrogen receptors and progesterone receptors, and their big success was HER2, which guides the use of a very effective treatment, Herceptin. Now, they're now using multiple gene expression measurements based initially on microarrays, but in some cases translated into RT-PCR platforms. And the two examples, and my sister had a breast biopsy, and it was sent to Oncotype DX, and she got back a number, 19. And if 19 is a good number, if it had been 76, that would have been really bad news. And so that what's happening is the molecular measurements are being compared to a database of hundreds or thousands of other people, and then her prognosis is being predicted by equations. And that's very useful because it eventually starts to learn more. It learns from the cases as time goes on, which is very much like your brain does over time in the clinic. So what we're doing is we're taking the system which we know and love, the system of Rudolf Virchow, from the Charity Hospital in Berlin, and we're adding Watson and Crick from Cambridge. And we think that we can get information about diagnosis, activity, stage, guidance for therapy or theranostics, measurement of response to therapy, and prognosis. And we can do this in transplantation and then go on to the rest of nephrology, the rest of inflammatory bowel disease, etc. So the system goes like this. We get a biopsy from a clinical trial or a patient in the clinic, and we start collecting the conventional information. For example, we like to have the donor-specific antibody. We like to get the histopathology. And then we assign a conventional diagnosis. And then one 18-gauge needle core, or a portion of a core, or in the case of gut or heart, bioptome bites, are then processed. Now, we can use a lot less tissue than that, but we want to get enough tissue to sample. We want a valid sample, and an 18-gauge needle core is plenty for an adequate sample. Then it's stabilized in RNA later, and then that's easy to work with. You could snap freeze it as well, but snap freezing means that it's difficult to handle in the future. You have to be very careful when you unsnap freeze it that you don't destroy the tissue. But RNA later is a very stable, and it's an excellent platform to work with. We can actually just drop the biopsy in RNA later. We can send it through the mail. So now we assign a molecular phenotype, and then this gives us a histomolecular phenotype, and then that information then can, through machine learning, can go back and help us create progressively more accurate classifiers. So we think that this is a central diagnostic system using microarray measurements of transcripts in the biopsy core to interpret the state of the kidney. It can assign the probability of T-cell-mediated rejection, antibody-mediated rejection, acute kidney injury, atrophy, scarring, and assign a more accurate prognosis than we've ever had in nephrology. Interestingly, there's no signal from calcineurin inhibitor nephrotoxicity, which is a point to discuss maybe later. So what we do is we collect the biopsies, we collect as much granular information as we can, we populate the database with all the other information we can get our hands on, and eventually the patients reach outcomes. These patients are very enthusiastic about this because once you're a kidney patient, you're always going to be a kidney patient, and they're very committed to the studies, and they ask us about it in the clinic. So these are prospective, consented, IRB-approved studies. So now we have two biopsy sets. The original Genome Canada study we call Biopsy for Cause 403, and the Intercom study, which I'll show you, is a validation set. We've worked out all the diagnostic system on the BFC 403, and we're simply validating the equations now on Intercom, as I'll show you. We don't use protocol biopsies because we don't think they're useful. Now, the molecular definition of T-cell-mediated rejection. First of all, you have to start to train the system, and we said to 3 excellent pathologists, help us by grading these biopsies independently, and they did, and then we compared their sensitivity and positive predictive value for one another. And so the sensitivity is about 50% agreement on whether a biopsy has T-cell mediated rejection. Now remember, these are abnormal biopsies, they're indication biopsies, and the agreement between 2 expert pathologists whose names you would know is about 50%. And then we looked across 3 biopsies in a subset where we had 3 pathologists, and the agreement was overall 45% sensitivity of one pathologist for another in the diagnosis of T-cell mediated rejection, which means this is a problem when you're creating the classifiers because you've got a circle of uncertainty around the truth. However, we then take the labels of the existing biopsies and we divide the biopsy set into 10, and these are called folds, 10 parts. We take use 9 parts then to create. First of all, we do t-tests to find the molecules associated with the phenotype. Then we use a method called LDA to create equations, which then predict. And we then predict the nature of the biopsies in the left-out fold. And we do that 10 times. Now every biopsy has a prediction. It's never participated in the equation that gave it a prediction. And then we do that 100 times. So now we've got 1,000 equations for assessing the system, but each biopsy has only been rated by an equation that it didn't participate in. So that's how the equations were generated to diagnose T-cell-mediated rejection and antibody-mediated rejection. Now the output looks something like this, and let me just walk you through this because it's kind of fun at the clinical level. These are the histologic diagnoses on the x-axis: antibody-mediated rejection, T-cell mediated rejection, mixed rejection, borderline, polyomavirus, glomerulonephritis, acute kidney injury, no major abnormalities. Some of these biopsies were up to 35 years post-transplant. It's whoever was in the clinic and had a problem and had an indication biopsy. Some are 7 days. So the whole case mix that you would see in the clinic, you're seeing on the slide. So here are the T-cell mediated rejection scores on the y-axis. Now the high scores are mainly in early biopsies, less than 1 year, which are gray. And they're almost always in many of them are in cases where T-cell mediated rejection has been diagnosed, but some are in cases where borderline was the diagnosis. Some are in cases where the diagnosis was antibody-mediated rejection, but we're finding that in fact it's not just antibody-mediated rejection, it's mixed. Some are in cases where there had been a lot of scarring and the diagnosis couldn't be made. So we're finding some new things about the population from the scores. Now, this is the signal that we're getting from the t-tests on T-cell mediated rejection versus everything else. What we're seeing is T cells and dendritic cells and macrophages talking. It's not the usual things that people have said were diagnostic of rejection. It's actually much closer to the T-cell synapse. So we're seeing T-cell signals associated with signal 1 and signal 2. Dendritic cell signals and immature dendritic cell signals, monocyte macrophage signals, and then a variety of interferon gamma-induced signals in the tissue. And that's what the t-tests have generated across 1,000 questions. Show us the T-cell mediated rejection molecules compared to everything else. If you ask it 1,000 different times, those are the molecules that come out. The score correlates with the lesions. So the presence of the lesions, the biopsies with high scores have a higher higher chance of having the lesions. So the score predicts across all the biopsies. It also predicts within the biopsies that have T-cell mediated rejection or borderline, it predicts the likelihood that you'll have tubulitis and what the score is going to be, and the likelihood that you'll have interstitial infiltration. Well, that's very satisfying. That's what you would expect. The score also predicts whether 3 pathologists will agree. So if the score is high, like in this case, at the bottom of this slide, the score is, when all 3 agree, the score is high. When all 3 say there's no T-cell mediated rejection, the score is very low. And the intermediate values reflect the inherent ambiguity in the current diagnostic system. The main errors in histology seem to be isolated V lesions. I'll show you that. Polyomavirus nephropathy, where T-cell mediated rejection often seems to be present, but the pathologist is reluctant to make the diagnosis. We call that trumping. If you see polyomavirus, you let it trump the possibility of diagnosing T-cell mediated rejection. Borderline is actually 2 sets of problems. Probably 3/4 are just acute kidney injury and inflammatory consequences of that, and then 25% are actually T-cell mediated rejection. Scarring gives false positives because tubulitis is invalid, and acute kidney injury scarring gives false negatives in histology because the tubulitis can't be scored. If the kidney is scarred enough, there's not enough unscarred tissue to score any tubulitis, so you can't have T-cell mediated rejection by histology, but you can have it, in fact. And of course, acute kidney injury gives inflammation, tubulitis, and interstitial infiltrate, and it can give you a false positive. When we looked at the isolated V lesions, we found that of 24 isolated V lesions in the biopsy set, only 4 had a strong T-cell mediated rejection signal, and the rest were either antibody-mediated rejection or acute kidney injury. Yet they are all being called T-cell mediated rejection by the BAMF system. So that's 20% correct or 80% wrong. So then when we're trying to put this together and get an idea of how the 2 systems work with one another, we initially find there's a lot of disagreements, and now we can get an accounting of the disagreements. So in the cell between histology saying other and positive scores, there were 18 biopsies. Almost all of these were attributable to known errors in histology. when the score was negative, but histology called it positive, that was due to incorrect isolated V lesions, recent parenchymal injury, and in some cases previous treatment had sterilized the molecular changes but left the histologic changes. So when we correct for those, we get a very strong agreement between the histology and the molecular score. The molecular T-cell mediated rejection has no impact on graft survival, just the same as histologic T-cell mediated rejection has no impact. Now what about antibody mediated rejection? So when we look at antibody mediated rejection, we've really got a problem. Because even after the last Banff meeting, the pathologists did not agree on how to diagnose C4d negative T-cell mediated rejection. Perhaps, antibody-mediated rejection, the commonest disease that we're going to see in the indication biopsies, but we can't make the diagnosis by histology. So this imposes a problem which is common across molecular medicine now, that the gold standard of making diagnoses is so poor that you have to take that into account. And the science of dealing with the flawed gold standard is emerging, but it's still moving on. If a perfect test faces a terrible gold standard, the perfect test would be thrown out if you're just looking at sensitivity and positive predictive value, because it's going to look awful. The truth will look awful when it's compared to a flawed gold standard. So how are we going to know? Well, you study the patients. That's how you're going to know it. It's going to take a long time, but that's where we're going. So now when we look at antibody-mediated rejection, the y-axis shows you the antibody-mediated rejection score, which is the endothelial activation signal. The x-axis shows you the same set of biopsy diagnoses. You can see most of the positive hits are in those where we had called antibody-mediated rejection either C4d positive or negative, or mixed. We're also getting a few hits in other areas. We're not sure of the significance of those. We have in the back of our minds as nephrologists that we know that there are other diseases of the microcirculation like membranous proliferative glomerulonephritis and thrombotic microangiopathy. We're not sure that we're seeing spillover of the signal into those diseases, but we can't rule it out. So this is what the signal is in antibody-mediated rejection. Again, this signal has come out from t-tests 1,000 times in which we've asked antibody-mediated rejection versus everything else over and over again, shifting the cases, mixing the cases up. So we get the main signal is from the endothelial injury repair response, which, as I say, is only seen in this disease. There's no other human disease we know of like it. And those are some of the transcripts. Then we get NK transcripts and interferon gamma-induced transcripts. The signal corresponds with the likelihood the pathologist will make the diagnosis. So when the signal is low, 0.09, 0 of 3 pathologists thought antibody-mediated rejection was present. When the signal was high, 0.49, all 3 thought it was present. So that's very reassuring as well. And of course, the molecular signal, without knowing anything else about the biopsy, strongly predicts survival. It's the best predictor we have in the early biopsies of survival. And we're seeing that, for example, in the Paris studies that we're doing with Alex Lupi. So this is the impact of the molecular signal independent of any knowledge of histology or DSA or anything else. And then when we do multivariable analysis, and this paper is accepted pending revisions in AJT, we find that the determinants of outcome, when we put everything on the table, are whether or not you have an antibody-mediated rejection score, although that's not very strong, whether you have a parenchymal injury response, and I'll show you that this afternoon, and then the function and the proteinuria, again for nephrologists, that's very reassuring. What drops out is scarring and inflammation in scarring. They're no longer significant. Okay, so the main errors in the histology diagnosis of ABM, in the diagnosis of ABMR are that the histology lesions are subtle and of limited specificity. They all have non-specific situations in which they can be called. transplant glomerulopathy versus MPGN can be a really difficult problem to sort out if the patient has a history of MPGN and now they've got DSA class 2. And this is really vexing. And perhaps some people have two diseases, which is difficult for any diagnostic system. The V lesion problem, currently people with an isolated V lesion are called T-cell mediated rejection, and this is wrong. Antibody-mediated rejection can give you that. C4D problems, I've alluded to, and of course donor-specific antibody is an emerging science, and that's not standardized, and the cutoffs vary from different centers, so that could have false positives and false negatives as well. In addition, of course, some antigen systems are not represented in the current DSA assessments. Not every center is measuring DP, and we're not sure about the significance of MIC-A and HLA-C. So probably we'll get negatives if people have pure antibody responses against an antigen system that we're not actually able to measure. So now we've gone to the INTERCOM study, which is a prospective consented study, IRB approved in Edmonton, Minneapolis, Baltimore, Manchester, Paris. Paris is actually participating in a subset, Barcelona and Hanover. And if you'd like to see the details, that's the clinicaltrials.gov number. So the case mix, and I'm showing you the case mix in the new study, which is in the right panels, shaded green, and the old study. And the case mix is basically the same. That's actually very reassuring that an indication biopsy study in another set of centers will actually get the same case mix as we had originally. So this is the case mix that you would get in any indication biopsy study, taking all comers at all times. And so we've got of the old study was antibody-mediated rejection. 22% of the new study is antibody-mediated rejection by histology DSA criteria. And just about around 10% of both studies are T-cell mediated rejection. 35 out of 403 and 32 out of 300. So now we can take the diagnostic criteria and not train it at all, but just do a test on the new biopsies, the unknown biopsies. So now we're looking, this is the test for T-cell mediated rejection, using the test that was worked out in the biopsy for cause 403 population. And we're finding pretty much the same performance, that we get a lot of positives in the early biopsies that have been called T-cell mediated rejection, but we also get some false positive histology, and most of these are isolated V lesions or acute kidney injury. Again, borderline is about 25% positive for T-cell mediated rejection, and some antibody mediated rejection is also positive. When we look at the failures so far in the study, and it's early days in the INTERCOM study, but many of those are antibody-mediated rejection as well. Those are the red balls. And then when we look at another set of endothelial genes to see, we find that the cases that are positive in the classifier have very high expression of endothelial genes, as we'd expected. So the highest quintile of expression of endothelial genes is always in the high score positive cases, indicating these are the cases with endothelial activation. When we look at the agreement with the, this should be with the antibody-mediated rejection score. No, this is the T-cell mediated rejection score. The T-cell mediated rejection score in INTERCOM agrees with the with the T-cell mediated rejection score in BFC 403 in terms of specificity, sensitivity, etc. So once we've made a correction for three things, isolated V lesions, borderline, and polyomavirus, we get an agreement with an accuracy of about 90%. The sensitivity is about 79% in INTERCOM, and the positive predictive value is about 78%. And the remaining problems are probably due to the problems of scarring and injury, producing false negatives and false positives. And this is what the AUC looks like in the new study compared to the original study. Very similar. These are the corrected AUCs. Now, in the antibody-mediated rejection, again, the antibody-mediated rejection score correlates with the microcirculation lesions. It also correlates with scarring because these are mostly late biopsies, and at the time when you diagnose antibody-mediated rejection, you almost always have scarring. It correlates with the presence of circulating donor-specific antibody, even though the test does not know whether the patient has donor-specific antibody, but the donor-specific antibody is positive. So when the score is high, when the DSA is positive, the score is much higher than when the DSA is negative. And in relationship to the diagnosis now, the y-axis again is the antibody-mediated rejection score, and the score is mainly positive in the cases, in late cases, red, and mainly positive in those that have a diagnosis of antibody-mediated rejection. But the intercom pathologists are not making the diagnosis quite as accurately as the original pathologists did because they haven't seen the system. So we're getting things like they're calling transplant glomerulopathy a lot in cases that are flagrantly antibody-mediated rejection, but they're not making that diagnosis. In some cases, they're not actually doing DSA assessments, and so they're missing diagnoses. So that seems to be what's going on in many centers, that antibody-mediated rejection is not being recognized. And yeah, this is, so what are we going to do with this? And then we'll take questions. So how are we going to use a new system like this? Well, first of all, it's to help understand. It's helping us to understand the cases, because in the process of generating this, you're actually getting the molecular biology of these diseases for the first time. And it's actually opening our eyes up to what the disease like T-cell mediated rejection actually is. We've seen this disease for 100 years, so now we're starting to see what the disease actually is in the tissues. It's not cytotoxic. It's an inflammatory process that's triggering the injury response of the parenchyma. So these are the kinds of insights we're getting. It can act as a reference standard to improve histology. So the histology system has incorporated some of the lessons from the molecular microscope studies. So you'll get better conventional diagnoses. We're trying to see if it can help calibrate DSA measurements as well. Find out what the cutoff should be in DSA measurements in people that have an active antibody-mediated rejection problem, for example. It can be a guide to therapy, we think, so that this signal, we hope, is something that if you can extinguish it, it will show that that's beneficial to the patient. So you could follow the signal in trying to see whether or not you've successfully treated the disease. That would be an important tool in the clinic, an important tool in clinical trials, and it would be important in helping industry to see that they can actually have some success in our field. It can act as an independent assessment of biopsies, so people are sending us problem-solving biopsies, and we've seen some very interesting situations now. People are sending us their biopsies in RNA later, and we're sending them back an answer, and we're following up on that. And finally, it can be integrated with the conventional diagnosis. Why are there discrepancies between these two major platforms? Why don't we have perfect agreement? Well, it's easy to say that there are histology errors like isolated V, donor-specific antibody errors, but there are also probably molecular errors. These equations may not be perfect yet, and we are going to have to refine the equations. I think that there is disease heterogeneity, and this is what we're seeing in breast cancer. Breast cancer starts out as a disease. It's now 60 diseases. And it's not going to be easy. You start out with a sort of global collection of all the cases that you think have the same thing, but you find out really they don't, or else one is active and one's not, one's at a different stage. So it could be activity stage, diagnosis, or disease heterogeneity, which gives us different answers with different platforms, and we're ready for that. And we think that there may be times when the signal becomes inactive. And if it becomes inactive, what's the significance of that? Does that mean your microcirculation is actually burnt out and it might be bad? Or does that mean the disease has become inactive and that your prognosis is good? So there's no shortcut. We're going to have to follow these cases. So in conclusion, I think histology alone is not going to meet our clinical needs, and it can't probably be improved much beyond its current 150-year performance. Other areas now are relying more on molecules and on the integrated phenotype. Don't think of this as competition. Think of this as an extension of what we can do clinically. And this area is being led by clinicians. Don't wait for pathologists to do it. This has to be clinical leadership. The molecules reveal the biology. They can correct errors, and they can offer very good screening systems. As the costs of microarrays come down, this test is going to be relatively cheap. And I think this will eventually succeed, but I just wanted to tell you a story. It's the sort of thing which would keep me awake at night, except everything else does anyway. But the story is this. It's the story of Rudolf Diesel. Rudolf Diesel was a brilliant German-French engineer in Paris, driven out of Paris by the Franco-Prussian War. They came back, and so he was working in the refrigeration industry, making motors, and he realized that there was a principle could be applied where you could have a high compression internal combustion engine in which the compression ignited the fuel, and it would be very energy efficient. And so he calculated, compared to steam technology, this would be 50% energy efficient, and in steam technology was 6%. Now, so he clearly had a better system. So in 1897, he gets a patent. Now, Mexico eliminated its steam locomotives, I believe, in 1963. Why does it take 70 years to adopt a better technology? Well, I'm thinking about this a lot. Institutional inertia. I have a perfectly good horse. Why do I need a car? Vested interest. The unions in the steam technology were politically very active and very concerned, and they should have been, because it was going to eliminate many, many thousands of jobs. And of course, diagnostic systems that are out of date it's a threat to out-of-date diagnostic systems. There are technical challenges. So poor Rudolf in 1893 found out the problems of making a high compression engine. It blew up in his face and put him in the hospital for 3 months. So there are engineering challenges with a new technology, and we're facing that too. How do you engineer this so it's a fully automated system? So far, it hasn't blown up in our faces yet. And then there's the cost. Initially, a technology which is going to be superior and is going to be widely adopted will have an initial capital cost and an initial operating cost above that of a conventional system. And initially, that's going to be bad because they're going to have to be duplicated. And part of the cost of the diesel locomotive was initially that it had to be run at the same time as steam locomotives were being running. So that was an add-on cost. And that's the way technology works. But don't be discouraged. Molecules are coming, and it's going to be good. So these are the things that we've covered, and I hope that I've been able to show you some things and to titillate you about the possibilities of applying this more broadly once we've learned these principles in the rest of nephrology. Thank you very much, and thank you for the wonderful opportunity to talk to you.